All right, good evening. On behalf of Dr. Greg Denier, President of the Scleral Lens Education Society and the SLS Board, I'd like to welcome everybody to tonight's webinar, Scleral Lens Complications and Troubleshooting. We have an outstanding panel of speakers today, Drs. Melissa Barnett, Mindy Toabe, and Lynette Johns, and I'm your moderator, Bruce Baldwin. I'd like to take just a moment to recognize our fantastic sponsors for the Scleral Lens Education Society, and those sponsors' websites can be found by linking to the Scleral Lens Education Society website, sclerallens.org. We have a full program tonight that will last maybe an hour, so we're going to ask that you hold off questions until after the last speaker. And at that time, we'll be able to take questions, and you can type questions into the chat box, which is located to the left of the whiteboard here. And you may want to have a pencil and paper handy and jot down notes, and at the end you can ask a question of a specific presenter, and you can refer to a specific slide, and the slides are up on the top of the whiteboard, and we can go back and review that slide. So our second speaker will be Mindy Toabe. Our third and last speaker will be Lynette Johns. But to start us out, we'll have Dr. Melissa Barnett. Melissa is a senior optometrist at UC Davis. Melissa, it's all yours.
Well, thank you, Bruce, and thank you to everyone for coming tonight. It looks like a great turnout. So first I'm going to go over handling of scleral lenses and lens insertion. So as we all know, the goal is a bubble-free insertion where we don't want bubbles under the lenses. It's important for the patient to bend over so that the patient's face is parallel to the horizontal plane. I like to have the patients look at a target like an Ansler grid when I'm training them to insert the lens so they actually have something of detail to look at, even if their visual acuity is not that great. It's important to fill the scleral lens fully with fluid. And as you can see here is a lens filled fully. For insertion, it's helpful to have a plunger, or you can use 3 fingers to hold the lens. When using the 3-finger method, the fingers are the thumb, index, and middle fingers. It's important to hold the eyelid open, and I like to ask the patient to hold the opposite eye open as well before placing the lens on the eye. The plunger method is just using the plunger as we saw in the picture, holding the eyes open and inserting it onto the eye. I tend to like the large plunger for insertion. For removal, it's possible to remove the lens with a 2-finger method. In this regard, you have the patient look down, you move the lower eyelid out while applying a little pressure, and then gently push the lower eyelid with the index finger to remove the lens. Here are 2 different plungers. You can see the large plunger and the small plunger. I find that patients tend to prefer one over the other, and it's not necessarily the one that I prefer. Of course, we don't put the plunger on the center of the lens, apply it to the periphery of the lens, and I like to twist and pull it away to remove the lens. When evaluating the lenses with fluorescein, at the initial evaluation, it's good to dip the fluorescein strip into the fluid-filled bowl of the lens and then evaluate the lens at the slit lamp in order to look at the initial fit and to make sure that bubbles are not present. It's nice to have the lens actually sit on the eye and settle for at least 30 minutes before really evaluating it, and then coming back and reevaluating the fit of the lens. At the dispense appointment, allow the patient to wear the lenses for at least 4 hours. So I like to see the patients in the morning and then again in the afternoon after about 4 hours to reevaluate the fit of the lens. First, evaluate if fluorescein is still present and if it's not, apply the strip to the conjunctiva to evaluate for fluorescein uptake under the lens. After a patient has been wearing lenses over time and seeing them on the follow-up visit, apply the fluorescein strip to the conjunctiva to see how much fluorescein uptake is taken under the lens. Instruct the patient to blink and then evaluate the fluorescein under the lens. This is helpful to look at the peripheral curve system too to see if fluorescein is readily taken up under the lens. Moving on to solutions, there are different types of solutions that can be used with scleral lenses. The first are gas-permeable lens disinfection solutions, and there are a whole multitude, as you can see. A multi-purpose solution can also be used, like the Boston Simplus solution here. For disinfection, peroxide-based systems are sometimes helpful, and this is a large container that can be obtained from the Dry Eye shop online for patients so that the larger than average lens can be used with a peroxide-based system. For cleaning, there are manual cleaners and alcohol-based cleaners, gas-permeable lens solutions, and soft lens multi-purpose solutions. But sometimes it's helpful to have a cleaning with a two-component cleaner, as you can see here. It's important to not store the lenses in saline due to the risk of microbial keratitis, and also important to avoid tap water. When applying lenses, a non-preserved saline is preferred in a single dose unit, and this can be used or in a bottle like the Unicel 4, as you can see here. Rinsing off the conditioning solution with the non-preserved saline prior to lens insertion helps with the fit and the comfort of the lens, and the initial vision too. The single-dose unit is a non-preserved 0.9% sodium chloride inhalation solution that is used off-label. This is used as a prescription, and it's a very low cost to the patient, even if it is not covered by their insurance. The patient obtains it from the pharmacy. Now, in some cases, a thicker sort of solution like Celluvis can be helpful when there are handling issues or if the patient is having trouble inserting the lenses, say if they're elderly. Diffuse staining can happen first for a toxic reason, and in that case it's important to minimize the preservatives if possible. Here you can appreciate all of the staining. So in this case it might be beneficial to switch to a single-use non-preserved saline. And it's important to evaluate the cornea without the lens with fluorescein staining to look for staining. If localized staining is seen, it could be due to a handling issue, insertion technique where an air bubble is causing the staining, or if a patient is having trouble removing the lens, if the lens edge touches the cornea, it may cause a corneal abrasion. Fenestration holes can also cause localized staining, and of course damaged lenses. Moving on to limbomicrocystic edema, this is more likely to occur when there's mechanical stress. Sometimes it's helpful to increase the limbal clearance or increase the dk over T in the material. Monitoring lens thickness is also helpful. If you see limbomicrocystic edema, it might be beneficial to ask patients about their vision, especially after wearing the contact lenses for many hours. A contraindication to scleral lenses are a low endothelial cell count. Other conjunctival complications are blanching caused by pressure on the conjunctiva, and here you can appreciate the blanching. Blanching might be due to a landing that's either too flat or too steep. However, if the blanching is under the entire area of the lens, it might be helpful to increase the landing zone by increasing the lens diameter. Blanching can also be caused by pressure on the conjunctiva. If it's sectoral, it could be due to an irregular scleral shape or pinguecula, and Lynette will come to this a little later. Impingement is where the lens edge pinches the conjunctiva. Negative pressure builds up behind the scleral lens with the blink, and the scleral lens flattens with the blink and fluid escapes the tear layer. Staining seen after lens removal, and this may cause conjunctival hypertrophy. If there are complaints of blurred vision or astigmatism on retinoscopy or refraction, evaluate for lens flexure. Keratometry or topography over the lens is helpful. It may be necessary to increase the center thickness to reduce lens flexure. Debris under the lens is a common problem with scleral lenses. It's more common in lenses 18 millimeters or larger due to a larger fluid reservoir and slower fluid turnover. Vision and comfort can be affected, and gas-permeable lens solutions may enhance the debris. Here, I hope you can appreciate all the debris under the lens. Advise patients to remove the lens, manually clean or rinse and reinsert the lens 1 to 2 times during the day. It may be necessary to have more frequent lens replacement and reduce the lens clearance if possible. Increasing the viscosity of the contact lens solution may also be helpful. It might also be helpful to loosen the peripheral curves or refit patients into smaller diameter lenses if possible. There's also lens surface debris. Evaluate the meibomian glands carefully and treat the eyelids aggressively. Also, make sure to flip the lids and evaluate for giant papillary conjunctivitis, and again, treat if necessary. Here you can see a picture of debris on the lens surface. Ask patients about what type of hand soap they're using, and also about when they're applying their face and eye creams and also makeup. This should be after the insertion of the scleral lenses. Change soap to contact lens hand soap. Here you can see an example of one, or special hand soap for acne treatment. It may be beneficial to change to peroxide-based solutions and also plasma treat the lenses. Thank you.
Thank you, Melissa, for that excellent presentation. Now, before I introduce the next speaker, I would like to get the participants to do something for me. If you'll look just to the left of the whiteboard, you'll see a green check and a red X. So if you're currently a member or a fellow of the Scleral Lens Education Society, I would like you to click that green check. And if you're not a member or fellow of the Education Society, please click the red X. And those of you that don't have a mouse, well, good luck. Okay, the other thing I'd like to ask you to do is type something in the chat area, which is to the left of the whiteboard. So if you would please type in the city and state where you are right now, or the city and country where you are right now, that'll give us an idea of the participants tonight. It'll also give you experience using the chat area, and that's what we'll use for asking questions at the conclusion of the presentations. Okay, thanks much. And just to remind the participants who have joined us since the beginning, we're going to hold off questions. We're going to hold off questions until the end of the third presenter, and you will have a chance to ask questions by typing into the chat area, and you can refer to a specific speaker, and you could also refer to a specific slide number, which is located in the upper left area of the whiteboard. And so our next speaker is Dr. Mindy Toabe. Mindy is at the Eye Institute at the Cleveland Clinic. She's also the Fellowship Chair of the Scleral Lens Education Society. So Mindy, it's all yours.
And I'd like to welcome everyone here tonight. Let's talk about ectasia. Ectasia is a protrusion of the cornea. Keratoconus is a non-inflammatory ectasia. Penetrating keratoplasty can develop recurring ectasia, and ectasia is also a complication of refractive surgery. There are no published guidelines for scleral fitting, but we do have options. We can look at the profile of a patient, and based on that, you can estimate the starting vault of a lens. So if the patient's cornea is flatter, go with a lower vault, and if the patient's cornea is steeper, go with a steeper vault. You can also look at the topography. And it's suggested that you start about 1 diopter steeper than the steepest K reading. In this example, the steepest K reading is about 52 diopters. In this patient, we were able to vault the cornea with a 54 diopter lens. If you have a patient that is progressing, consider fitting the scleral lens with excessive vault. In other words, consider leaving extra room for the progressing condition. Compare the cornea, which is about 500 microns, to the posterior reservoir. A posterior fluid of about 150 microns to 400 microns is acceptable. So you may want to vault the cornea up to about 400 microns. In the slides this evening, most of the lenses will be of the Jupiter design. The Jupiter design has an optic zone of about 8.2 millimeters, and the mid-peripheral corneal curve, or first peripheral curve, has a total width of 4 millimeters. The total corneal vault is 12.2 millimeters. The second peripheral curve vaults the limbal area with a total width of about 2 millimeters, and the third and fourth peripheral curve land on the sclera with a total width of about 4 millimeters. The standard diameter is about 18.2 millimeters. Some patients have severe keratoconus and can develop hydrops. Patients with hydrops secondary to keratoconus have a 65% prevalence of mitral valve prolapse, which is greater than the normal population and even that of patients with keratoconus who have up to about a 58% prevalence of mitral valve prolapse. Patients with corneal hydrops should visit their primary care provider and, if needed, be referred to a cardiologist. In terms of fitting a patient with advanced keratoconus, there may be more vault inferiorly than centrally due to corneal thinning. The first peripheral curve may be significantly flatter than the base curve. In this example, the first peripheral curve is close to 12 diopters flatter than the base curve. Ever wondered why some patients with keratoconus seem to desperately need a lens in the poorer eye and others can't tolerate it? There was a study done which revealed that binocular function breaks down with long-standing asymmetric keratoconus. This is due to unilateral visual deprivation. Without a scleral lens in the worst eye, all patients had exotropia and suppression. With a scleral lens, over half the patients had aphoria, most had no suppression. This patient wears a soft toric contact lens in the right eye and a scleral lens in the left eye. Without a contact lens in his left eye does wander, and with a contact lens, his visual acuity is 20/25. This patient chose a scleral lens because of comfort. He could not tolerate any other lens designs. Some patients have severe, with respect to Pellucid Marginal Degeneration, there is a hypothesis that there are actually two types of Pellucid Marginal Degeneration. The majority of patients have a milder form of Pellucid Marginal Degeneration and a minimal risk of corneal perforation. But there may be a small percentage of patients who have an overreactive immune response involving an interleukin-1 dependent mechanism. If this mechanism is excessively active, this could increase the risk of corneal perforation and create a more severe form of Pellucid Marginal Degeneration. So in this example, the central base curve vaults the cornea, and we have central apical clearance, but the mid-peripheral curve is too flat. By steepening the first peripheral curve, central clearance will be achieved. Some patients have severe dry eye. A scleral lens holds a reservoir of fluid that is independent of the tears. This tear reservoir does not dehydrate over time and helps with severe ocular surface disease. This patient had a penetrating keratoplasty with persistent epithelial defects. The scleral lens helped with the severe dry eyes. A reverse geometry design was used in this case, where the first peripheral curve was about 2 diopters steeper than the base curve. Some patients develop ectasia after penetrating keratoplasty. Recurrent ectasia is often bilateral and tends to recur about 20 years later. After a penetrating keratoplasty, host keratocytes slowly replace donor keratocytes. Both host and donor tissue become thinner at the graft-host junction, contributing to recurrent ectasia. The cornea is weakest biomechanically at the inferior quadrant. That is where the cornea will become the thinnest. When fitting a patient with a very steep cornea, as in this case, you may need to increase the lens diameter significantly in order to vault the cornea and land on the sclera without impingement. In this case, the lens diameter is 20.6 millimeters. Fitting a penetrating keratoplasty with ectasia may require a design where the first peripheral curve is flatter than the base curve. In the first example, the first peripheral curve is about 11 diopters flatter than the base curve. In the second example, the first peripheral curve is about 3 diopters flatter than the base curve. There are complications associated with refractive surgery. Epithelial cells can migrate under the stromal flap after LASIK. Larger areas of ingrowth occur about 20% of the time after LASIK, with the risk increasing with enhancement. If the peripheral cornea is steeper than the central cornea, a reverse geometry design will be needed, as in this example, where the first peripheral curve is about 1 diopter steeper than the base curve. This patient had LASIK in 2008 after multiple cataract surgeries. The patient had dry eyes, was contact lens intolerant prior to LASIK surgery. She came to my office with severe dry eyes, wearing sunglasses, having a lot of pain and photophobia. I prescribed oral antibiotics to decrease the inflammation and added artificial tears. Scleral lenses reduce the pain and light sensitivity due to severe dry eyes. The shape of the cornea in this example is normal, even after refractive surgery. A standard lens design worked well, as in this case, meaning that the first peripheral curve is about 0.4 millimeters flatter than the base curve. When fitting a patient with severe dry eyes, decrease the tear reservoir as much as possible. In this case, the tear reservoir was about 150 microns. Tear debris can form in the post-lens fluid reservoir or on the front surface of the lens, causing decreased vision. Educate the patient with severe dry eyes about periodic lens removal. Front surface cylinder can be laid on the lens to correct residual astigmatism. A successful front surface toric design requires being able to maintain the position of the lens. Scleral lenses provide constant stabilization. Here's an example of a front surface toric lens on a patient with a history of ectasia after penetrating keratoplasty. Visual acuity without the toric design was 20/40 with a doubling effect. Visual acuity with the toric design was 20/25 to 20/20. Sometimes a patient may have an irregular scleral surface where the lens will cause discomfort and local blanching of conjunctival vessels. Back surface toric peripheral curves can be laid onto the back surface of the scleral lens. This will also help in cases where air bubbles become trapped under the lens. Corneal edema and compromised endothelial function are contraindications to scleral lens wear because it increases corneal swelling. Specular microscopy assesses corneal endothelium, and endothelial cells that show variability in size and variability in shape are considered to be under stress and abnormal. To assess endothelial cell function and evaluate the corneal response to a scleral lens, place a lens on the cornea for about 4 hours and monitor central corneal thickness and the corneal epithelium. This is especially important for eyes that have had a penetrating keratoplasty or have compromised endothelial function. Scleral lens-induced central corneal swelling can be decreased as the DK increases and lens thickness decreases, but the relationship is nonlinear for higher oxygen-permeable materials, meaning that minor differences in DK between two lenses would not make a significant difference in decreasing corneal edema. If corneal edema does develop, assess the scleral fit. If the scleral fit is good, then consider fenestration, decreasing wearing time, or refitting into a corneal lens. Corneal thickness is an indirect measurement of the corneal endothelial pump function. Corneal swelling averages up to 18% during contact lens wear compared to about 4% during eye closure. This is a patient with a history of LASIK-induced neurotrophic epitheliopathy. The pachymetry reading before lens wear and on a previous visit was 537. The pachymetry reading after wearing this lens for 2 hours was 618. The lens was tight along the second peripheral curve, creating limbal edema and vascular impingement along the third and fourth peripheral curves. The visual acuity also decreased by 2 lines. At the next visit, I modified the lens and flattened the scleral curves, the third and fourth peripheral curves. The pachymetry readings were stable after an hour of wear, indicating no corneal edema, and the visual acuity was unchanged. The lens I used had Boston XO2 material and a DK of 141. Thank you.
Okay, thank you very much, Mindy. That was another outstanding presentation. And it looks like we're doing really good on time, so there should be plenty of time for questions and answers after our third presenter for tonight, and that would be Dr. Lynette Johns. Dr. Johns is a senior optometrist at the Boston Foundation for Sight. Lynette?
Thank you, Bruce. I want to thank all the participants for attending today and also thank our sponsors. If you're not currently a member of the Scleral Lens Education Society, it's a great resource, so I highly recommend it. So I'm going to deviate from the keratoectasia portion and discuss severe ocular surface disease and scleral lens issues. In our office at the Boston Foundation for Sight and our partner clinics, we like to simplify the goals of the FIT to 3 simple themes. The first being improving vision, second, improving comfort, and third is support of the ocular surface. So you can see these are a variety of categories of ocular surface disease that benefit from scleral lens use. And it's just a short list of what we see. And you can see the severe dry eye benefit for improved comfort, sometimes improved vision, and in particular anesthetic corneas. The support of the ocular surface is a primary goal. One of the most common complications of severe ocular surface disease with scleral lens wear is debris, and it's a common running theme that you've probably heard through Dr. Barnett and Dr. Toabe's discussion. It can happen inside the lens chamber and also on the front surface of the lens. What's helpful is to actually establish your patient's expectations prior to the fitting process. So it's not a surprise when they're battling with it because you and the patient will be battling with this problem. You can predict the front surface debris based on their entering baseline staining also. And sometimes it helps you manage the patient and how you're going to treat them. And managing the debris from the front surface versus the chamber can be managed completely differently. So here's an example of exposure keratitis. These are 2 separate patients, and it shows the fluorescein picture. You can see the inferior, more than 1/3 aspect of the cornea has dense staining, and so this patient is not having a complete closure of the lid or a complete excursion, and that whole inferior aspect is desiccating, and you can expect that the scleral lens front surface will desiccate as well. And in addition, you can see an example of a post-blepharoplasty patient, and this is right here, and you can see she can't close her eyes, and this area is definitely going to desiccate with lens wear. And here's an example of that exposure zone-related front surface debris. And then with severe ocular dryness, in the cases of Sjogren's and graft versus host, you have overall dense staining, and this also this filamentary mucus that's going to accumulate on the front surface of the lens. And again, this isn't any surprise. You'll have this diffuse staining pattern. So let's discuss front surface debris and how to manage it. You can polish the front surface of the lens, but you have to be mindful that if the lens is plasma treated, you're actually going to eliminate the surface plasma layer. You have to remember this plasma is not a coating. It's actually a treatment to the surface molecules, and they've been transformed to become more hydrophilic. You can replasma lenses, and I would recommend contacting your local laboratory to see if they provide that service. It might be a charged fee. You could discuss with your patient scheduled midday removal and refreshing, or as needed. We have what's called the squeegee technique, where we moisten a cotton swab with either saline or their artificial tears, and instead of removing the device, they actually leave it on the eye and swab the front surface, and they're able to identify an object across the room and see if they've gotten all the debris off. We recommend increased lubrication of the lens throughout the day, so artificial tear use. And you want to also reevaluate the care and handling of the lenses, remove any potential sources of preservatives that they could react to, consider adding enzymatic cleaner, and also punctal occlusion. So here's an example of a front surface wetting defect, and if this is a brand new lens and this keeps happening no matter how many times you clean the lens or recondition the lens, it's likely that you might want to consider plasma treating the lens, or if it is supposedly plasma treated, send it back, or consider a change in the material itself. And now this is another example. We have our patients that have their favorite lens that they don't want to part with. So an aged lens will have what's called crazing to the surface. And it's very similar to pottery crazing. And you can see this whole like breaking apart of the surface here. And if you send this lens for a replasma treatment, it's only going to make that worse. So if they really like that lens and their vision isn't impaired and you're happy with the fit, as long as it's clean, try not to damage it further by replasma treating that device. Switching gears, we're going to talk about the chamber debris. And here you can see this all of the little particles. And sometimes it's helpful to actually just look at the particles themselves and see what type they are. Mucus tends to be white and fluffy, and meibomian debris tends to be gold little flakes and glittery. And that can be helpful because if it's the meibomian debris, you might want to look for underlying lid disease. So what we like to do is find the path of debris. So this is where fluorescein is your best friend. You want to see the path of fluorescein exchange underneath your lens. So if you're seeing it in a 360-degree pattern, chances are you're not tight enough at your edge, and so you might want to tighten your outer curves. But in general, what you want to think about is to have more scleral lens alignment to the scleral surface, and that will prevent the debris from having an easy access path to that chamber. Also, look for a toric pattern. So if you see exchange basically 180 degrees apart, suspect a toric anatomy. You can use viscous preservative for your artificial tears inside the lens, and it could be filled up, half and half, or a few drops and topped off with saline, and that prevents a thick barrier from debris from getting inside the chamber and becoming visually significant. And again, as always, evaluate the solutions and the eye drops and eliminate any preservatives that the patient might be using. If complaints of debris are only in the morning, where the patient will say, oh, I put my lens in, an hour later it fogs up, but then once I refresh it, I'm great for the rest of the day, well then this is where an eye cup can be very helpful. The patient can soak the eye in the morning before they put their lens in, and it'll remove all of the debris that's stuck onto the eye, and they should be a lot better. And again, treat the underlying lid disease. In this case, you could pull the plug. Sometimes the plug is exacerbating the debris condition. So here's an example of a toric pattern. This is actually an oblique pattern. So if you want to just kind of use your imagination, you can see it's coming in this way and also coming in this way. And this is where toric curves can make a huge difference on eliminating that path for debris to enter. Switching gears, symblepharon management is very important when you're treating patients with limbal stem cell deficiencies like Stevens-Johnson syndrome, ocular cicatricial pemphigoid, and also chemical burns. Some eyes cannot be fit, and these are the cases of keratoblepharon or symblepharon to the cornea. A good goal is to fit inside the symblepharon to prevent inflammation of this tissue. This tissue can become very reactive, and you don't want to cause a situation where the symblepharon can advance. Another helpful tool is to actually notch or scallop or cut out the edge to accommodate the symblepharon. But when you do that, you also have to be very careful of how far in you notch. One, you can notch too much and have air extrusion underneath and bubble extrusion underneath the chamber of the lens. And if you don't notch it out enough, the symblepharon could actually still push the lens and decenter it to the opposite side and cause impingement on the other side. And then lastly, an extreme management is to recommend symblepharon lysis surgery with mitomycin C. Symblepharon treatment is challenging because they do tend to recur. So here's an example of a symblepharon to the cornea. If we were to fit a lens onto this eye, it'd have to be an extremely small diameter, but you can imagine if we put the edge of the lens right here, and the patient were to look down, it would destabilize the lens, and probably the lens could fall out or just air would get underneath. And there's no real benefit to a patient having to struggle with keeping the lens in the eye throughout the time. Now this is a quieter eye, and you can see the area of this symblepharon. You've got plenty of room to fit a good diameter without actually interfering with this tissue. And in this case, it's very difficult to evert a lid on a severely dry eye patient. And a lot of those patients are in pain and they can barely open their eyes to talk to you in a dimly lit room. So the last thing you want to do is avert their lids, but sometimes you'll be surprised what you find. And this is a case of ocular cicatricial pemphigoid. You can see there is not much room. This is pretty much all connected. I was still able to fit a device in this eye, but basically it was a small diameter, and what's very important in these situations is to have the edge very well tapered so it's not too sharp and not too thick to exacerbate that tissue. And in some cases, I've heard in other settings to use a scleral lens as a conformer. This patient was referred to our office for that very reason. A patient with retinoblastoma, enucleated the left eye as a child. She had radiation to the right eye and a recurring symblepharon that had been surgically treated. And so she arrived at this point, and we fit a larger lens on this eye, and we fit kind of flat here, trying to prevent this symblepharon to advance. But it didn't quite work. The tissue had a mind of its own, and you can see in this area just the bulk of this tissue that's not having a lens interaction had advanced just in a few short months. So this same lens from this eye has now been decentered. The eye is more angry. It's a redder eye. You're seeing more compression. And basically about a year and a half later, that whole tissue thickened up quite well. And the patient was really unable to tolerate a lens as we were starting to decrease the diameter. And she ended up electing to have another symblepharon lysis procedure. And so this is where she was last year. Again, this is the same lens that was featured in the last slide. And again, you can notch or scallop the lens as well, but you always have to be mindful on the other side. And tarsorrhaphy management is also very tricky. These patients have very fragile surfaces. That's why they have the tarsorrhaphy in the first place. And the tarsorrhaphy can show itself in many different ways. It can be just laterally in the corner. It could be 1/3. It could be 2/3 with only a small area to peak. You could have this bridging type of tarsorrhaphy. And it's very important to have a clear understanding of what the goals you're trying to achieve for fitting. Is it to support the surface? You want to discuss with the cornea specialist who's referring how to manage this patient and actually have a clear understanding of if the tarsorrhaphy is to be taken down and when the patient is to first be fit. You don't want to delay the fitting from the time of the tarsorrhaphy being taken down, because if they're prone to epithelial defects, they will break down. And so try to attempt applying the lens without taking down the tarsorrhaphy. If you can do that, that's great, and then see if the patient can do that themselves, because keeping that tarsorrhaphy is extra protection for when the lens is not in. You want to have a clear plan with the patient and the cornea specialist how to manage the eye when there is no lens. Now here's the situation where basically you've got dense staining, very dry eye, and after 4 hours of wear, most of that staining is eliminated. That's most commonly what we see with scleral lens and dry eye. So if you see worsening of staining, you should suspect something else. So there are surprises after the lenses come out. And so you always want to be mindful of, if there's staining, start scratching your head and look for other problems. So I would suspect medicamentosa if you see diffuse corneal staining, conjunctival hyperemia, and increase in debris. Also, always be suspicious for microcystic edema, and if a patient's complaining of rainbows, then start looking for the edema. If you see any arcuate staining, then you can suspect patients applying the lens decentered. And this is a case of bullae after the lens came out. The lens was a well-fit lens. There was fluorescein exchange, so we ruled out suction. The patient had a 3,300 endothelial cell count. In fact, this patient was a GVHD patient. After more probing, had abruptly had a strong taper of his systemic prednisone and was having a significant GVHD flare. So sometimes the problem isn't the eye, it's the whole system. And here's a case of an application error where this patient was rolling up as she applied her lens. Fortunately for her, the epithelium didn't break, but it definitely rolled up on itself. And here's another picture of that same area. And so we treated her by just aggressive lubrication, and that seemed to iron itself out within 2 days of this incident. And again, microcystic edema you always should be mindful of. It's best to be seen in indirect view. And the patient also will be noticing rainbows around lights and grayed vision. So it's helpful to just shine a light in their eye and ask them if they see rainbows after lens wear. And when you have microcystic edema, evaluate the solutions that they're using with lens care and their drops. They might be reacting to some preservative of some sort. You also want to make sure that the lens is not suctioning, and you must refit if necessary. And you can increase the diameter if you're running into suction, because that will provide more tear exchange because of the asymmetry more peripherally from the cornea. Increase the decay of the material, and you can fenestrate to eliminate suction and increase oxygenation. Oops. This is a case of a gentleman who had a 20/20 graft, but he had a significant ectasia of the graft, and no surgeon wanted to operate on a patient that had a 20/20 graft with a lens. The problem was after 2 to 3 hours of a non-fenestrated lens, he developed microcystic edema. With a fenestrated lens, he did not develop any microcystic edema, and he achieved 15 hours of wearing time. So fenestration can be a powerful tool. And lastly, I want to discuss neurotrophic corneas. These patients have no sensation or limited sensation, so you have to rely on other cues. And this is where it's very important to have a near perfect fit. You don't want to have any impingement that could cause a reactive hyperemia to the tissue, and be mindful of it. Hypervigilance and immediate assessment if there's any complaint of redness, because that's their only way of knowing that something could be going on. Aggressive lubrication when the lens is out. And in this case, it's questionable, and it's up to your discretion if you want to use antibiotic prophylaxis. Thank you very much for your time.
Okay, thank you very much, Lynette, for another outstanding presentation. You know, I've looked at these slides a number of times, formatting them to get ready for the webinar, but now that I've had a chance to actually sit here and watch them and listen to the talks, I actually learned quite a bit tonight, and I hope that our participants have learned a lot also. So let me give one more shout out to our supporters, and again, the Scleral Lens Education Society website is sclerallens.org. So let me give one more round of thanks to our three speakers for tonight, Drs. Melissa Barnett, Mindy Toabe, and Lynette Johns. So at this time, if anybody has questions for any of the speakers or a question in general, you can type that question into the chat area here to the left of the whiteboard, and we'll see if we can't get somebody to answer your questions. Well, while people are thinking, I think I have a question for, I think I'll ask Dr. Barnett. You know, just about everybody you talk to who fits the scleral contact lenses has a different set of solutions that they recommend for cleaning and for sometimes insertion. So, Melissa, I wonder if you would care to comment about what type of solutions that you use.
Sure, I think that's a great question, and it really depends on the patient. So for, say, a standard scleral lens patient, and none of them are standard, I would use like a low bob cleaner with a Boston conditioner. But if they're having any buildup under the lens or on the surface, then I'll switch to a hydrogen peroxide-based system like ClearCare.
Okay, thanks. And we do have a question. This is for Dr. Johns. Dr. Johns, please repeat regarding front surface non-wetting. And I know there are some patients that just have really, really bad non-wetting contact lenses. And so this participant wants you to make another comment regarding the non-wetting of the surface of a scleral lens.
Well, what I've found is that sometimes it's just the patient's tear chemistry and the material, the polymer itself, are just incompatible. But plasma treatment is just a wonderful tool. So if your lab is capable of doing it, which I think most labs are, I recommend a replasma treatment of that lens. Otherwise, switching the material. When we find wetting defects in our office, sometimes we just wash the lens again with, we use ESC cleaner or Boston laboratory cleaner. We do avoid the Boston abrasive cleaners because we don't want to eliminate the plasma treatment to the surface, and those tend to be a little more abrasive. And then sometimes we use Boston original conditioner, but sometimes cleaning it is enough if it's well plasma treated. I hope that answers your question.
Okay, thanks. So here's another question. I'll throw this out to all three speakers. The question is, what scleral, is one lubricating drop better than another for scleral lens use? And I have a comment if it's not covered by one of you three.
So I guess I can start. When inserting the lens, I like something a little bit thicker in viscosity. With insertion, something like Opti or Soluvisc. However, on top of the lens, I prefer something a bit thinner, like a non-preserved refresh. And these will all be non-preserved drops.
I recommend.
Go ahead, Linda.
Go ahead. We use just whatever the patient prefers. The severe dry eye patients tend to be very brand specific for themselves, and so we just recommend what they came in using prior to being fit with a scleral lens.
In our practice, I find that it is sometimes useful if you have a patient with very dry eyes to use a preservative-free artificial tear, and you can put it directly into the scleral lens upon insertion, or the patient can use a non-preservative solution such as Unisol and put that right into the scleral lens prior to insertion.
Yeah, I agree. I tell my patients to avoid anything in a bottle because they all have preservatives. So anything in a single-use, non-preserved lubricating drop, whether it's a contact lens re-wetting drop or an artificial tear, I think is what I recommend. This participant says, I find it very difficult to evaluate the fluorescein tear layer on follow-up when so little fluorescein reaches the apex of the lens. Any suggestions? How about Melissa?
What I like to do is just gently press on the conjunctiva with my finger to try and get some fluorescein up under the lens, both inferiorly and superiorly. I find that that's helpful.
That sounds good. And one thing I do is I put way too much fluorescein in the inferior cul-de-sac so that it's sometimes even dripping down the cheek. And I like to overload with fluorescein because I want to see if there's a good amount of uptake of fluorescein within the first 5 minutes or so. And if there's not, then the landing may be a little bit too tight. On the other hand, if you have huge amounts of fluorescein going immediately underneath the lens, then maybe there's a little bit of edge lift somewhere and the landing needs tightening some. But another thing you can do, if you don't get anything in about 5 minutes, and I think you said this, Melissa, have them look down and take my thumb on their eyelid, and you can sort of pump some fluorescein up under the superior edge of the lens to at least get some under there so that you can evaluate the vault.
That's correct. I am pushing up against the eyelid to push up against the conjunctiva to get that fluorescein under the lens.
What I usually do is I place the slit beam and I just watch as the fluorescein gets underneath, and you can see with the slit beam, even if there's a little bit of fluorescein dye present underneath the tear reservoir.
Okay, here's a good question, and it looks like it's addressed to the three speakers as well as Dr. Denier. And the question is, if you're using ClearCare, if a patient's using ClearCare for a cleaner, do you still find it necessary for the patient to rub the lens? After all, if you look on the box, it says right there, no rub. So what do you think, Pamela?
I usually will prescribe ClearCare, and if the patient is having a problem with depositing, I will add a cleaner to the system as well. For example, I would use the Optimum Cleaner, and I would have the patient clean the lens first digitally, and then rinse it, and then put it in the ClearCare solution overnight.
I wonder, does anybody just say, don't worry about manually cleaning your lenses, just put them in the cage and watch it bubble?
We always use a cleaner, the ESC cleaner, or the MiraFlow, or the CVS generic MiraFlow equivalent with the ClearCare system.
I think that's probably a good idea, and in that sense, then you don't have to rub it with the ClearCare. You're using the ClearCare mainly then for disinfection. So here's another good question. This is directed to Dr. Barnett. You had a photograph and you mentioned the large cases for the hydrogen peroxide systems. The question is, what do you do about the neutralizing disc?
Well, from the dry eye shop, it does not come with the neutralizing disc, so I guess you would purchase the ClearCare and that with the large case.
So is the case just for storage, or are you actually disinfecting the lens in the case with ClearCare and then transferring it to the case with the metal disc in it?
It's just a larger version of the case, like the ClearCare. Am I able to put an image on there, Bruce? No, probably not. But if you just look,
do you want me to bring up the image? Do you want me to bring up the image with that large case?
Sure.
Okay.
You just use it like the ClearCare system. It's just a different case, so it will neutralize there too.
Have I gone too far?
That's okay. I just find that it's helpful in the patients with the very large diameter lenses, but it's not needed for all patients when I use clear care.
Yeah, most of your screw cap cases, if you get a lens that's over 20 millimeters in diameter, some of the smaller cases like that comes in the renewed kit, they're a little bit small for a 20 millimeter contact lens. Okay, here's a question for you. Dr. Johns mentioned treatment for debris under the scleral lens. Do you recommend the same treatment for a standard keratoconic patient who does not have dry eye? I.e., is it still an issue of steepening the peripheral curves?
Absolutely. You want to increase your alignment with the sclera to prevent having path for debris and exchange to get in. Basically, you're trying to decrease the amount of fluorescein exchange. One thing that we've found through the years is that fluorescein exchange, while is helpful, it's not always necessary to see it. So you could have a patient that has a lens in for 8 hours, and you can take it and you can put fluorescein in, and it doesn't get underneath. And it doesn't necessarily mean the lens is too tight. It just means that you've got significant alignment, and you want to assess how much suction you have when the lens comes out. If there's suction, you're too tight. But oftentimes, if the lens comes out easily, it's okay, and that will reduce the amount of debris. That's a big problem. So you don't have to have fluorescein exchange to have the perfect fit. You just have to make sure you don't have suction.
All right, thank you. I hope that answers that question. And here's one directed at Dr. Toabe. The question is, what was the specific recommendation for common mid-peripheral apical touch at the superior nasal area? And I believe she's referring to the slide, and while you're answering, I'm going to try to go get that slide, where there was good vault centrally, but you had mid-peripheral touch and touch out towards the limbus. And so the question is, how do you fix that?
I'll pull that slide up. There we go. The central area, if you have clearance in the central area, leave it alone and steepen the first peripheral curve. So if you have mid-peripheral touch superiorly, you would still steepen the first peripheral curve.
Okay, I think that's the answer the participant was looking for. I know sometimes you can make a rather small increase in the diameter of the lens to bridge over the limbal area as well. Okay, here's a participant that asks, first of all, he says, excellent presentation, doctors, and I second that motion. Do you typically use Boston Exo material or another such as Minicon Z?
Oftentimes I'll use an Exo material or an Optima material.
Lynette, what's the material of choice there at the Boston Foundation for Sight?
We were FDA approved for Equilens 2 for large diameter lenses, and we use Exo 2, but Exo 2 is not FDA approved for diameters over 17 millimeters. So you have to be very careful and chart appropriately why you're choosing to use that material in a diameter that large.
That's a really good point. I think there's quite a bit that we do in the scleral lens fitting world that would be considered off-label. Okay, here's a really good question. What is the acceptable amount of microns regarding a tear reservoir, especially in a dry eye patient? Is it better to have more than less? Why don't, Melissa, why don't you start out with that, and then we'll see if Mindy or Lynette has a comment.
So in the number of microns, I'm sort of estimating how many microns are under the lens. I'm not imaging actually the lens in my practice, but I guess I would say an even amount of a tear reservoir under the lens. And that's a tricky question if it's better to have more than less. Of course, you don't want any touch, so you don't want not enough clearance. However, there can be complications with excessive clearance as well. So again, somewhere in the middle.
When you have a dry eye patient, I believe it's better to have a little less tear reservoir than more, because less debris will accumulate underneath the lens. So if you think of the cornea as having about 500 microns and an acceptable amount of tear reservoir is somewhere between 150 and 400, so either the thickness of the cornea or a little bit less, you'll want to err on the lesser side, about maybe 150. And just make sure there aren't any areas of touch and that you do have complete clearance throughout the central curves.
Lynette?
I agree with both Drs. Barnett and Dr. Toabe. If you're really battling the debris problem, dropping down the vault a little bit can make a huge difference. But if you're not having excessive exchange, then I could make the statement it doesn't matter. I tend to fit very generous vaults. So if you see any of my fits, you might see a very generous vault, and just because I want to really focus on the alignment with the sclera, and once I'm evaluating the vault and I know I'm cleared, I don't want to look at it again because I really want to be looking at the haptic more or less. So it's just a ease of fitting for me, so I'll fit generous, and so I've never seen any complications of just going too steep with a generous vault.
When you say generous vault, would you say 250 microns is generous, or 400 is generous, or greater than 400?
Greater than 400.
All right, that's a good pointer. I think I'm going to start fitting with much larger vaults in some of my patients. So,
actually,
Melissa...
sorry to interrupt. One fitting technique that's very helpful is fitting a generous vault on an ectatic patient, in particular pellucid, or a young keratoconus patient who's showing rapid advancing. And in the case that they're not going to have corneal cross-linking, you want to give them a little bit more room to grow, essentially, because otherwise they're going to be contacting the back surface.
That's a really good point. I just saw a 22-year-old that I fit about a year and a half ago with not generous vault, but adequate vault, and she shows up with an apical touch in both eyes, and I had to refit her after just a year and a half. So that's good advice. Tend towards a little more generous then. And Melissa, here's a question. Someone's asking for who's the vendor for that large lens case. I think you said you could get it from the Dry Eye Zone, but do you know the specific manufacturer of that caged lens case?
I typed it out as well, the dryeeyeshop.com. I do not know the specific manufacturer. Lynette, would you?
We actually designed that lens at the Boston Foundation for Sight and provided it through the Dry Eye Shop to make it available to all scleral lens patients. So I don't think you can get it directly through the company. I think the only vendor is the Dry Eye Shop, and it's very accessible. And they have the plungers there. It's a great resource for all patients, not just dry eye patients, but keratoectasia patients as well.
Okay, that answers Dr. Harmon's question as well. The next question is, what scleral lens companies will do a front toric on scleral lenses? And I know the Boston Foundation for Sight can make very custom lenses, but let me ask Mindy first, do you know specific companies that can put a front surface toric on a scleral lens, since you had that one photograph of the scleral lens, the toric markings.
Visionary optics will do a front surface design on a scleral lens, and visionary optics will also do toric peripheral curves when needed. And in addition, scleral lenses can be plasma treated more than one time, as Dr. Johns mentioned earlier.
So Melissa, do you know another manufacturer other than Visionary that can make a front toric?
I do not.
Dr. Johns?
I believe Trueform can do front surface torics.
I think you may be right. Let me just ask this, the follow-on to that same question. If you did have a patient that truly has residual astigmatism, and it's not due to lens flexure, so you can't fix the residual astigmatism by making the lens thicker. If they truly have residual astigmatism, Mindy, how do you actually go about making that lens and getting it to stay aligned on the eye?
Well, in that example that I showed you, and I had two cases recently where I have fit a front surface toric design. I basically do the over-refraction, and when I know for certain that it is residual astigmatism, then when I'm talking to the lab, I will let them know the amount of residual astigmatism, and then the lab will actually, lay the front surface toric onto the lens itself.
Dr. Johns, could you comment on the manufacture of both front and back and/or bitoric scleral lenses?
The bitoric can be tricky if the axis of your optical axis does not align with the scleral toricity axis, but oftentimes there's alignment with that. We incorporate also front surface eccentricity of varying degrees, and that a lot of times masks these problems with front surface toricity that you need. And in keratoconus, you'll see that it's really not lenticular still that's coming through. It's just it's their residual higher order aberrations that's causing this approximation of an astigmatic effect. So, so it can be tricky only if the axes do not align.
Okay, good comment. And it's my understanding that most eyeballs are actually toric, and can be sometimes relatively easy to get a back toric lens to align with the eyeball. So here's a good question. Have any of the presenters used anterior segment OCT for scleral lens fitting? And if so, has it been successful? And which OCT have they used? And, Dr. Denier, you can chime in on this one here too if you'd like.
I have not.
We have an anterior segment OCT at the Cleveland Clinic Coli Institute, and on occasion I will use it, but generally speaking, I have not found it necessary in the actual fitting process.
I have the Vasanti OCT, and I use it a lot, and particularly several years ago when I first started fitting scleral lenses, it was very, very helpful to look at the vault of the lens in 3D and then correlate that with what I was seeing with the slit lamp. And at this time, I don't feel like I need to use the Vasanti very much, but they make such really good photographs, and it's in the room right next to mine. I still use it quite a bit.
We have the Visante also.
Here's a question: does hydrogen peroxide affect plasma treatments at all? One lab was concerned about this, and I think my answer to that would be I don't think so, because the plasma treatment simply well, who was talking about plasma treatment? That was Lynette. Lynette, would you like to answer that question about does hydrogen peroxide affect plasma treatments?
Well, we've done no studies on it, but pretty much we have a plasma machine in the office, so that's how we're able to replasma all of our patients' lenses, and it varies for when they actually return them back to us for retreatment. In some cases it could be 1 to 2 months, and sometimes it's every 6 months or so. I don't think the breakdown is so much the peroxide as much as it is digital handling.
Okay, here's a good question. Have any of you dealt with fitting sclerals following cross-linking? And if you have, what period of time do you wait before starting the fit? And have you found that changes continue to occur to the cornea affecting the fit even after the fact? I think I've only fit one patient with cross-linking. He had cross-linking and intacts in each eye, and it was essentially a straightforward scleral lens fit. So maybe someone has more experience fitting patients that have had cross-linking. Anybody?
I've had one case of a patient who had corneal cross-linking and intacts, and I'm currently in the process of fitting him now. We had to halt the process because he developed a corneal melt right along the intact area and had to have that intact removed. So I'm just starting to refit him again. So I haven't had any long-term experience with corneal cross-linking at this time.
I've had about 3 now, and as far as the fitting window, I think once the epithelial defect has resurfaced, it really is up to the surgeon if they're comfortable with starting the fit, because in essence you're jumping over the cornea, so there's no harm there. And I actually have one of the patients I have is a 13-year-old boy that had the cross-linking done in Germany, and so I followed his topographies over the past 1.5 years, and he's been markedly stable, and considering he's a 13-year-old boy with KC that was rapidly advancing, it's quite impressive.
All right, thank you very much. And Jill Bryan asks, what companies offer a quadrant-specific option for scleral lenses? Actually, we have an answer from Afe, and he says Trueform does. Trueform has quadricone and I think some other options for quadrant-specific curves. Anybody else?
The Boston Foundation for Sight does, but unfortunately we don't have trial sets for providers. So if a patient is really requiring a unique fit, you could refer to either the Boston Foundation for Sight proper at Boston or one of our partner clinics. They have this technology available to them.
Okay, well, it looks like we still have about 20 participants who stuck it out this long. We've been going almost 1.5 hours now, so let me thank our speakers again. Dr. Melissa Barnett, Dr. Mindy Toabe, and Dr. Lynette Johns, and also our very fine sponsors. And there's another webinar that is tentatively scheduled for, I believe, June, so you can watch the Scleral Lens Education Society website and look for that date. So if there are any other final comments from any of our participants or Dr. Denier, let's hear it.
Well, Bruce, thanks a lot for moderating. You did a wonderful job, and as well as all the speakers. I'll just say to you that our next webinar is tentatively scheduled for July 12th, and Dr. Vanderwerp will be giving some information on scleral lens shape.
Okay, so with that, I bid everybody a good night. Thanks for joining us, and we'll see you on the next SLS webinar. Good night.